Hello, colleagues, and a very warm welcome to this advanced clinical review. I'm absolutely thrilled you could join me today from wherever you are in the world. We're diving straight into a topic that has fundamentally transformed how we manage postoperative pain in orthopedics, the Adductor Canal Block, or ACB, for total knee arthroplasty. Now, before we get bogged down in the data, let's just take a moment to reflect on the immense clinical burden of a total knee arthroplasty. As we all know, it's arguably one of the most painful elective orthopedic procedures we perform in theater. And inadequate analgesia in that immediate post-op phase, well, it's not merely a comfort issue, is it? It triggers a whole cascade of severe clinical consequences. It massively delays early mobilization, which then exponentially increases the risk of DVT and pulmonary embolism. It completely derails necessary physiotherapy, leading to arthrofibrosis and stiff joints. And crucially, it drives up high systemic opioid consumption, bringing along its own devastating risks of post-op nausea, vomiting, ileus, and the very real danger of chronic opioid dependence. As anesthetists, we're constantly chasing that perfect physiological balance, aren't we? Providing immaculate opioid-sparing analgesia while simultaneously preserving full motor function so our patients can actually get out of bed and mobilize on day one. For years, the ACB has been our absolute holy grail for achieving this balance. But here is the truly fascinating part. Recent, highly granular anatomical and clinical evidence strongly suggests that many of us might not actually be performing a true adductor canal block at all. Over the course of this explainer, we are going to rigorously dissect the latest evidence, from freshly published cadaveric studies detailing millimeter-specific anatomy, right through to the definitive meta-analysis comparing continuous catheters, single shots, and femoral nerve blocks. We'll be looking at standard deviations, confidence intervals, and precise methodological data to elevate our practice. We're taking this strictly from the bench to the bedside.
Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. We welcome the anesthesiologists who are working hard today to provide regional anesthesia for postoperative pain control. Aj Anesthesia or Perioperative Medicine channel for हमारे साथ जुड़ने के लिए धन्यवाद। हम उन anesthesiologists का स्वागत करते हैं जो आज ऑपरेशन के बाद दर्द को नियंत्रित करने के लिए क्षेत्रीय anesthesia प्रदान करने में कड़ी मेहनत कर रहे हैं。感谢您今天收看麻醉与微手术期医学频道。我们欢迎各位麻醉医师，他们今天正辛勤工作，为病人提供术后疼痛控制的区域麻醉。
All right, let's quickly run through our agenda. We'll cover the anatomy and critical zone, ultrasound and clinical technique, continuous versus single ACB, ACB versus femoral block, a review of pharmacological adjuncts, and finally, clinical guidelines and checklists. Starting right off with Section 1, Anatomy and the Critical Zone. Let's start by totally deconstructing the anatomical foundation of this block. Have a look at the left side. We see the traditional surface landmarks we've all historically used in our training, right? Drawing that linear trajectory from the anterior superior iliac spine, the ASIS, down to the superior pole of the patella. It's what we were all taught. However, the image on the right from Gupta and colleagues' 2026 cadaveric study published in Acta Anesthesiologica Scandinavica fundamentally redefines this geometry. It's a brilliant piece of work. They meticulously dissected 30 lower limbs and identified a highly specific critical zone. This zone represents exactly the proximal 3.5 centimeters from the true origin of the adductor canal. Now, why is this important? Because within this exceptionally narrow corridor, the saphenous nerve, or SN, and the nerve to the vastus medialis, the NVM, travel incredibly intimately together. The statistical data from their measurements is quite profound. The minimum distance between these two critical nerves is a mere 3.5 millimeters. That's tiny, with a standard deviation of plus or minus 1.8 millimeters, and an absolute range from 1.4 to 8.3 millimeters. To put that into perspective for our daily practice, a single properly placed bolus of local anesthetic in this specific 3.5 centimeter zone is pretty much guaranteed to bathe both nerves simultaneously. Plus, their dissections confirm that both nerves consistently lie lateral to the femoral artery in the specific segment, which brilliantly minimizes our risk of inadvertent vascular puncture. For our clinical practice guidelines, they note that the true start of the canal can often be mapped by finding the intersection of the AB line and the MP line, what they call the R point, and moving exactly 7 centimeters distally. Injecting there and ensuring a 3 centimeter proximal and distal spread will fully encompass this critical zone. Building upon that spatial redefinition, Wong et al.'s landmark 2017 volunteer ultrasound study in regional anesthesia and pain medicine brilliantly illustrates exactly why the traditional landmark technique has been leading us slightly astray all these years. Just notice the spatial relationship between the arrows on this sonogram. The red arrow signifies the classic midpoint of the thigh that anesthetists have historically targeted. Conversely, the blue arrow precisely marks where the apex of the femoral triangle truly resides, which is the genuine anatomical beginning of the adductor canal. The researchers measured 22 healthy volunteers and found a striking discrepancy. The mean distance from the ASIS to the actual start of the adductor canal was 27.4 centimeters, with a range spanning from 24.0 to 31.4 centimeters. In absolute contrast, in all 22 volunteers, a literally 100% incidence rate, the midpoint of the thigh was located significantly proximal to the actual start of the adductor canal. So the clinical takeaway here is absolute. If you're performing a classic mid-thigh injection based on surface anatomy, you are, by definition, performing a femoral triangle block, or FTB, and not a true adductor canal block. It's a bit of a paradigm shift, isn't it?
Which brings us to the formal clinical definition of our ultimate target, the critical zone. It is strictly defined as that proximal 3.5 centimeter segment from the beginning of the adductor canal. Now, mechanically and histologically, why is this specific segment the absolute gold standard for our injectate deposition? Beyond the extraordinarily close 3.5 millimeter proximity of the saphenous nerve and NVM we just discussed, the cadaveric data revealed a structural anomaly that works entirely to our advantage. The vasto-adductor membrane, that thick, fibrous fascial roof of the canal that can sometimes be so stubborn, is actually absent in approximately 50% of anatomical specimens within this specific proximal segment. This means that if we precision target this critical zone, the nerves are highly accessible to our local anesthetic. They aren't compartmentalized or shielded beneath a thick, impenetrable aponeurotic membrane. By targeting this exact microenvironment, we achieve dual nerve coverage with optimal local anesthetic spread, while practically neutralizing the risk of significant vascular injury, as the vessels remain distinctly medial to our needle trajectory. It's an absolute win-win.
Moving on to Section 2, Ultrasound and Clinical Technique. Right, let's transition to the actual sonographic execution of this anatomy. As regional anesthesists, pattern recognition is our primary tool, isn't it? We invariably commence by scanning proximally and sliding our high-frequency linear probe distally along the trajectory of the superficial femoral artery. What we are seeking with absolute precision is the apex of the femoral triangle, that exact sonographic moment where the medial border of the sartorius muscle intersects the medial border of the adductor longus muscle. You can observe this muscular transition beautifully in the left panel here. As we slide just distal into the actual canal, we actively look for the characteristic double contour of the vastoadductor membrane, which is clearly highlighted by the cyan arrows in the right panel. Bearing in mind our cadaveric data, if we're positioned accurately within that proximal 3.5 centimeter critical zone, this membrane might appear exceptionally thin or be entirely unidentifiable. This perfectly facilitates an incredibly clean, unobstructed, in-plane approach from lateral to medial. The saphenous nerve will typically present as a distinct hyperechoic structure immediately adjacent and anterior to the artery, whilst the NVM lies just slightly lateral to it, often embedded within the fascial plane of the vastus medialis itself. So let's crystallize all of this into a rigorous, actionable procedural sequence for when you're next in theater. Step 1. Identify the femoral triangle apex where the sartorius meets the adductor longus. Step 2. Target your needle insertion to capture that exact 3.5 centimeter critical zone. Step 3. We strictly utilize an in-plane lateral to medial approach. Now, why do we explicitly choose the lateral to medial approach over the transsartorial approach? Well, think about it. The transsartorial trajectory requires traversing the highly vascularized sartorius muscle belly and often aims directly at the femoral vessels, which obviously increases the risk of inadvertent vascular puncture. In stark contrast, the subsartorial lateral to medial approach, coming through the vastus medialis, offers exceptional parallel needle visualization and places the needle tip safely beside the artery, exactly where the saphenous nerve and NVM are congregated. This proximal lateral spread achieves a concurrent block of both nerves while keeping the injectate high enough in the canal to result in minimal distal popliteal spread, thereby avoiding any unwanted motor block of the posterior leg. Just for context, remember that the saphenous nerve typically crosses the superficial femoral artery at the adductor tubercle plus 14.9 centimeters. We are aiming significantly higher than that. Finally, step 4. Volume. Current consensus guidelines mandate 15 to 30 milliliters of 0.2% to 0.5% ropivacaine. For single-shot blocks, a volume of 20 milliliters is statistically optimal for ensuring adequate proximal and distal spread along that critical corridor, without causing clinically significant quadriceps weakness. Oh, and a vital technical note for those of you placing continuous catheters. Use a TUI needle and deliberately advance your catheter merely 1 to 2 centimeters beyond the needle tip. Any further and you risk kinking or dislodging it right out of the canal.
Section 3. Continuous versus single ACB.
To systematically evaluate the clinical efficacy of continuous catheters versus single injections, we absolutely must analyze the pivotal 2019 randomized controlled trial published in the Korean Journal of Pain by Kim and colleagues.
The methodology here is really robust. They took 44 patients scheduled for unilateral TKA under general anesthesia and randomized them strictly into 2 arms, with 22 patients in each group. Group CACB received a continuous ACB catheter, running 0.2% ropivacaine at an infusion rate of 5 milliliters an hour, supplemented by patient-controlled boluses of 5 milliliters with a 15-minute lockout. The control arm, Group IV-ACB, received a robust single-shot 20 milliliter ACB of 0.5% ropivacaine, combined with a standard intravenous fentanyl PCA running at a basal rate of 0.4 micrograms per kilogram per hour. The primary outcome data is highly significant. Let's evaluate the total morphine equivalents consumed over 48 hours. The continuous catheter group averaged just 10.5 milligrams, with a standard deviation of plus or minus 8.7 milligrams. In stark contrast, the single-shot plus IV-PCA group averaged 23.8 milligrams with a massive standard deviation of plus or minus 22.9 milligrams. This yielded a statistically significant p-value of 0.016. Consequently, due to this profound systemic opioid-sparing effect, the incidence of rescue antiemetic administration was significantly higher in the single-shot group, producing a p-value of 0.046. The numbers really speak for themselves here. And the chronobiology of the pain response further cements this superiority. When we map out the numerical rating scale, or NRS, pain scores across a precise 48-hour timeline, the pharmacological limitations of a single injection become glaringly evident. At the 30-minute, 4-hour, and 24-hour postoperative marks, the continuous group already demonstrated superior pain control. However, I really want to draw your attention specifically to the crucial 48-hour mark. This is where the clinical superiority of the continuous catheter is most pronounced. The single-shot block, despite utilizing a highly potent 20 milliliters of 0.5% ropivacaine, invariably and completely wears off between 18 and 24 hours. And what happens when that regional blockade dissipates? The patient is left entirely reliant on the IV fentanyl PCA. This directly triggers the massive spike in systemic opioid consumption, which then directly correlates with a subsequent spike in postoperative nausea, vomiting, and delayed bowel function. The continuous infusion circumvents this entirely. It provides a beautifully smooth, unbroken, and reliable perineural analgesic baseline right through the most excruciating phases of early orthopedic rehabilitation.
Now, a perennial concern among our surgical colleagues is whether an ongoing continuous infusion of local anesthetic will precipitate a profound motor block and delay critical physiotherapy. We've all fielded those anxious phone calls from the ward, haven't we? Well, notice the trajectories on the Medical Research Council, or MRC, scale graph presented here. There is absolutely no statistically significant difference in quadriceps muscle strength between the continuous catheter group and the single-shot group. Kim's team rigorously tracked quadriceps power from the preoperative baseline entirely through to postoperative day 4. Both groups experienced the physiologically expected decline in muscle power on postoperative day 1 due to surgical trauma and tourniquet time, but remarkably, they recovered strength at an identical rapid trajectory. The continuous infusion of 0.2% ropivacaine provides vastly superior opioid-sparing analgesia without sacrificing a single measurable unit of quadriceps strength. So you can firmly reassure your surgeons on that front.
Section 4, ACB versus the traditional femoral block.
To address the comparative efficacy against historical standards, we need to scrutinize Zhang et al.'s rigorous meta-analysis from the journal Orthopedic Surgery, which pooled 11 high-quality RCTs encompassing 675 patients. First, establishing the baseline. When comparing the ACB to a saline placebo, the ACB unequivocally dominates pain control, demonstrating a weighted mean difference in analgesic consumption of minus 12.84 milligrams, with a 95% confidence interval spanning minus 19.40 to minus 6.27, yielding a p-value of less than 0.001. No surprises there. However, the true test is ACB versus the deeply entrenched historical gold standard, the femoral nerve block. When comparing opioid consumption and pain scores between these two blocks, the weighted mean difference is a negligible minus 0.56 milligrams, with a very wide 95% confidence interval spanning minus 8.05 to 6.93, and a non-significant p-value of 0.884. This statistically confirms that ACB and FNB provide entirely equivalent postoperative analgesia. Yet, when we shift our focus to functional outcomes, a massive divergence occurs. The standardized mean difference for quadriceps strength overwhelmingly favors the adductor canal block, with an SMD of 0.99, a 95% confidence interval of 0.04 to 1.94, and a statistically significant p-value of 0.041.
Furthermore, metrics for nausea, vomiting, and sedation showed no statistically significant differences between the two groups.
The clinical translation of that meta-analysis essentially dictates our modern enhanced recovery after surgery protocols. The adductor canal block effectively matches the femoral nerve block in terms of raw sensory pain control. But the reason it has universally replaced the FNB in modern orthopedic pathways is its significantly superior preservation of quadriceps motor function. Because the ACB is performed far more distally, targeting purely sensory branches and the specific nerve to the vastus medialis, it completely spares the vast majority of the afferent motor branches to the quadriceps femoris complex. This neuromuscular preservation leads directly to statistically faster ambulation times, specifically measured and validated by superior performance on the timed up and go, or TUG tests. Moreover, it completely eradicates the catastrophic risk of postoperative falls resulting from buckled knees, which is a well-documented and heavily litigated complication associated with continuous femoral catheters. We achieve equivalent pain control combined with vastly superior patient safety profiles. It's a real game changer.
Section 5. Let's do a review of pharmacological adjuncts. Let's pivot slightly to perineural pharmacology. Agarwal and colleagues recently published a monumental scoping review in BJA Open in 2025. They screened an incredible 285 articles and meticulously analyzed 130 RCTs to decipher the absolute optimal pharmacological strategies for the adductor canal. Let's examine the evidence regarding perineural adjuvants. Perineural dexamethasone has proven high-quality evidence across 3 distinct RCTs, demonstrating that it significantly extends the duration of the sensory block and directly reduces postoperative opioid consumption. Similarly, dexmedetomidine has shown proven efficacy in 3 RCTs, substantially extending the duration of single-shot ACBs through its action on hyperpolarization-activated cation channels. However, magnesium sulfate presents a much more complex clinical picture. The review found highly conflicting results regarding its efficacy. Why the discrepancy? Well, it largely stems from a lack of standardized dosing and the fact that magnesium's NMDA receptor antagonism is heavily dose-dependent. Furthermore, the varying degrees of systemic absorption from the adductor canal versus true perineural action on the nerve axon create immense variability in these clinical trials. Therefore, based on the highest level of currently available evidence, dexamethasone or dexmedetomidine remain the scientifically sound choices for prolonging block duration, while magnesium requires much further robust standardization before routine perineural adoption.
The BJ Open Scoping Review also resolved several other really pressing pharmacological debates we've been having in the specialty. First, regarding local anesthetic formulations. Some studies indicated that liposomal bupivacaine yielded slightly longer durations than standard bupivacaine or ropivacaine, though cost-benefit analyses remain hotly debated and standardization is definitely lacking. Regarding volume strategies, the pool data confirmed that 10 milliliters of 0.5% ropivacaine was functionally non-inferior to 20 milliliters for single-shot blocks in terms of resting pain scores. However, analyzing 5 RCTs looking at proximal versus distal injection sites, while most showed no difference, some data suggested proximal ACBs resulted in better opioid-sparing profiles. Crucially, regarding continuous versus single-shot techniques, an analysis of 7 meta-analyses yielded mixed results on long-term pain superiority, but all agreed functional outcomes are identical. Lastly, the absolute gold standard established by this massive dataset is combination therapy. The ACB really shouldn't be used in clinical isolation anymore. Combining a precisely placed ACB with surgeon-administered local infiltration analgesia, or LIA, is statistically superior to either technique alone. And to combat the notoriously difficult posterior capsule pain driven by the sciatic plexus, pairing the ACB with an IPAC block, infiltration between the popliteal artery and the capsule of the knee, provides phenomenal, comprehensive 360-degree knee coverage whilst rigorously sparing all major motor pathways.
And our final section, number 6, clinical guidelines and checklists.
Before we even introduce a needle in the anesthetic room, rigorous adherence to a pre-block checklist is absolutely paramount. First, verify your anatomical landmarks. And consciously override that obsolete mid-thigh dogma we discussed earlier. We are exclusively hunting for the true apex of the femoral triangle. Second, optimize your sonographic equipment. High-frequency linear probes are non-negotiable for visualizing the delicate double contour of the vasto-adductor membrane and measuring that tiny 3.5 millimeter distance between the SN and NVM. Third, execute strict pharmacological selection. Draw up your 0.2% to 0.5% ropivacaine and explicitly declare if you are compounding with dexamethasone or dexmedetomidine based on your catheter strategy. And finally, of course, ensure baseline patient hemodynamic stability and adhere strictly to your institutional stop before you block laterality protocols. If there is one singular takeaway to commit to memory from this entire review, it's this master summary table right here. It precisely synthesizes the exact clinical parameters required for the highest possible success rate based on the aggregated 2025 and 2026 data. Let's walk through it methodically together. Your target must be the 3.5 centimeter critical zone, located just proximal to the start of the true adductor canal, bypassing the vastoadductor membrane. Your approach is strictly ultrasound-guided, in plane, lateral to medial through the vastus medialis, explicitly keeping your needle tip lateral to the femoral artery to minimize vascular injury. Your volume should be calibrated between 15 and 30 milliliters of ropivacaine to guarantee optimal spread to both the saphenous nerve and the NVM without causing profound distal popliteal spread. And finally, your best combination therapy, the ultimate multimodal protocol for the modern orthopedic theater, is the adductor canal block paired inextricably with surgical local infiltration analgesia and an IPAC block for comprehensive posterior capsular coverage.
To synthesize our core clinical translation arc from the bench straight to the bedside, step 1. We must collectively and definitively abandon the anatomical myth of the mid-thigh injection. If you're halfway down the thigh, you're performing a femoral triangle block and potentially missing the optimal dual nerve bundle entirely. Step 2. Consciously seek out and precisely target the exact 3.5 centimeter critical zone where the vastoadductor membrane is frequently absent and nerve accessibility is at its highest. Step 3. Intelligently utilize evidence-based pharmacologic adjuncts like perineural dexamethasone to safely stretch the duration boundaries of your single-shot blocks. And step 4, proceed with absolute confidence knowing that by rigorously adhering to these metrics, you are providing robust, FTMB-equivalent analgesia whilst fully preserving quadriceps motor function for immediate day zero orthopedic rehabilitation.
We have established unequivocally today, through deep statistical and anatomical review, that the meticulously placed adductor canal block is the absolute gold standard for primary total knee arthroplasty. It represents a massive triumph of targeted, sonographically driven regional anesthesia over systemic opioid reliance. However, as we look toward the future frontiers of our specialty, I want to leave you with a provocative thought to ponder. With this anatomical superiority now firmly established in primary joints, how will we adapt and optimize these precise continuous catheter techniques to manage the severe, neuropathic, and chronic pain complexities so frequently associated with massive revision total knee arthroplasties? Unlocking that challenge is definitely the next great frontier for us as regional anesthesists. Thank you so much for your time, your attention to the data, and your clinical expertise today. I trust you'll integrate this highly granular, updated evidence directly into your operating theaters. Cheers, and see you next time.